has ever really known really what the treatment is or what it's doing or how it's working. And you just know what they're getting a mask and they're going to be sleeping with a mask, and I think they just stop snoring. That's what most people have come to believe. And I'm going to try to do some clarification through the different variations of treatment, because it's not all CPAP. There's multiple different types. So, what it is, what it does, why we need it. There's the CPAP, APAP. They're considered the same type of machine, even though they slightly work differently. There's BiPAP or VPAP. It's a little bit more advanced. There's then the BiPAP, BPAP with the ST, and I'll explain that, and then the ASB, which is the most advanced treatment, generally speaking, for sleep apnea. That's pretty much what one of the machines look like. It's one of the most popular machines a person is going to be using in a home setting. CPAP is also used in the hospital setting. It can be a very common form of use. There are people who may have to go to the hospital for various reasons, and they get put on a CPAP. Part of the reason that they would use it in a hospital is to prevent having that wonderful tube down your throats. And that's one of the things that is being used right now for that COVID-19. People are going into respiratory failure with the coronavirus, and it's really filling their lungs up with fluids, and they need any sort of ventilatory support they can possibly get, and PAP therapy is being used in a hospital. It's the primary go-to, would be, an intubation, ventilation, but there's a lot of complications that are involved with that. It's invasive. There's risk of pneumonias, there's risk of bacterial infections. So this is a non-invasive ventilation. Nothing's going into your body besides air. So the CPAP itself, generally it keeps your nose, it splints the airways from the beginning where the mask touches. So the mask's going to start somewhere in the nose, mouth, and it provides a pressure. The pressure opens, expands your nose, something like a balloon. Just a simple concept, just inflates the throat. Of course, in sleep apnea, it's preventing somebody from choking and gasping while they're sleeping, keeping their oxygen levels from dropping. And again, as I said, in the hospital, it's allowing for your lungs to be open, better oxygen exchange, help your lungs work a little bit more efficiently. When you breathe in, you get a nice heavy boost of air. The air inflates your lungs. When you exhale, you breathe against air pressure. This is one of the hardest things about CPAP that takes a long time for a patient to kind of adapt to, is the feeling of breathing against pressure. I have some techniques that I work with patients who are really fighting air pressure. They may feel like they're being overwhelmed with air. They may feel like they're being either force-fed the air or like suffocating with it or choking with the air. There's some breathing exercises and techniques I have them do with the machine and their masks to more or less calm them down, adapt to them. And a couple of the techniques that I use, like the taking a big deep breath and holding it, breathing out slowly with the air. In person it works incredibly well. A patient definitely helps being coached through these elements. CPAP. It's what everybody has heard of when it comes to this form of treatment, or they like to call it CPAC or whatever variation of PAC or PAP treatment they have. It stands for continuous positive airway pressure. So basically that is a one steady stream of air that's being pushed into you. And that air is variable, and it's adjusted typically during a sleep study. When a person comes in for a sleep study, they can have a couple different types. A split night study, for example, where a person will sleep for a period of time, all wired up, and evaluate to see if they have any breathing episodes or issues breathing. They get then put on a CPAP, and the sleep study technician will slowly start to elevate pressures to find a pressure that works. It kind of dials in a set pressure, or it gives us a really good blueprint of where you might be for the next step treatment, which would be the auto PAP. And as also I see here, I put in here, there's the auto CPAP trial. It's not done very often anymore. It's something that I did way in the past, back before, back when people were struggling. You'd put them on an auto CPAP for a week or two and let them adjust pressures and find a pressure that may work well for them, and then we'd program their CPAP to do that pressure. Again, it's the most commonly used treatment. It's the first line, and honestly, most patients do well. I see 90% plus patients do great with this particular treatment. And then we have APAP. It's kind of the direction that most people are going these days. It is, again, basically the same thing as a CPAP. It just has the ability to adjust pressures independently throughout the night based on the patient's needs, which is, in my opinion, really beneficial. I'm a big fan of APAP. I find that when a patient gets started with an APAP, they can have a very generic setup, and some of that's based on the way sleep studies are done these days, more of the home studies and such. But when a patient can come back and see me at their follow-up visit, like after the first month or two on treatment, we can really start to fine-tune stuff, adjust the pressure ranges, and manipulate things to better suit you as an individual, finding a perfect kind of window or pressures where you're not over-pressurized, not under-pressurized, you're comfortable, and then, of course, you know, the mask element. Now, these two forms also have a comfort feature built into them. There's the EPR or C-Flex. Now, this is honestly a feature that most patients don't even know they have. It's either programmed on, it's either programmed off. Sometimes it's subjective to the DME that they get the machine from, the respiratory therapist who sets it up, and sometimes it's ordered by the doctor, but honestly, patients don't even know they have it. But it can be a make or break in the treatment world. What it really does is that back pressure I was talking about, where it feels like you're being pushing against air, it kind of relieves it a bit. It makes it a little bit more natural to exhale. A patient who I find it would maybe struggling with treatment, fighting the air pressure, and I look at the reporting and the EPR is off. They don't have it. And then I'm sitting in the office with them and I'm adjusting the settings with them in front of them while they have the mask on, they're breathing with it, and I'm tweaking the EPR settings, letting them feel the difference while they're awake, and they can distinctly feel the relief when they exhale. And it smooths out the therapy, and it's almost instantly like a light bulb clicks in there. Oh, yeah, I like this. I can do this. This is something I want to do. You know, the other thing about an APAP machine is it does adjust pressures. And of course, it's adjusting pressures based on the demands of the person. Now, a general definition of an apnea is a 10-second breathing pause. And these machines have to wait at least 10 seconds for a response. Otherwise, it could get aggressive if, you know, you took a yawn or just had a breath and it was a longer breath, and then the system started to go aggressively at you. So the new style machines, they will wait 10 seconds for this apneic event, and then it will send these slight pulses and puffs of air, little light puffs. And it's really just gauging, are you breathing that in? You breathe it in, system stops. You don't, it starts to increase. And it is waiting for that blockage to be overcome, to have the air come in. The system will then start to tail off, and it'll hang out there before it starts to reduce. And it reduces to a point to, ideally, it can go back down to the baseline, whatever the low-end pressure limit is, so to speak. Again, I like the treatment. Some, you know, I've had other doctors, they like, you know, CPAP, they swear by CPAP, but, you know, APAP is kind of the direction everything's going with the general frontline treatment of sleep apnea. Then we got the world of the BiPAP, the VPAP. BiPAP is exactly how it sounds. Two, bi meaning two, positive airway pressure. V stands for variable. They're the same thing. The two different manufacturers got in a battle about copyrights, and they had to come up with new names for the same thing. It's just like Nike and Reebok, they can't copy each other. But, you know, the idea of a BiPAP machine is it is more advanced. It costs more money. There's a kind of a process to get it. I personally think it's more comfortable to breathe with just because it gives a more exaggerated inhale and exhale pressure. The main reason that the person would go on this is that they're not tolerating the CPAP or APAP at all. Like the CPAP or APAP at the home setting is either too much air pressure or it's just uncomfortable to breathe against. They just can't get enough relief when they exhale. So a BiPAP, you can control how far the exhalation goes down. You can have a 3, 4, 5, 6 point exhalation out of the machine. And the idea is you can also go higher in air pressures on a BiPAP machine, because if a patient needs high power or high pressure to keep themselves breathing, and the CPAP itself might feel like you have your head, you know, stuck in a car window doing 100 miles an hour, never letting up, the BiPAP will allow that let up to happen. And as I put on here, of course, it can be a more natural form of therapy. The BiPAP is also something you're going to see more commonly in a hospital setting. They don't use a lot of CPAP, but they will use a lot of BiPAP. The BiPAP itself, again, is designed for better oxygenation. It ventilates the patient better. So if a person is in respiratory failure, you can get more air in and out of the patient. Again, one of the things that's being used with the treatment for the coronavirus, with patients with respiratory failure, having difficulty breathing, lungs filling with fluids, they're going to start to try to really move some air fast. The pressures on the BiPAP do go a little higher, and again, the reason for it is it's a little bit more advanced treatment. Patients who have worse sleep apnea, lots more events, they will a lot of times transition to this treatment just because they need more power. The inhaled pressures can adjust based on the variability of the severity of apnea or how much the size of the patient might vary. If you have a big patient, they might need more of an inhale pressure. Just opening everything up requires less work for breathing, just, again, more comfortable. What was I going to say? Yeah, it's used in the hospital for the congestive heart failure, COPD, asthma. Also, we're seeing it for the COVID situation right now. BiPAP ST. So as I was mentioning with the BiPAP, the variable pressures, inhale, exhale pressure. The ST stands for spontaneous timed. Basically what that means is, as I put an example down here, this IPAP stands for inhaled positive airway pressure. It's the pressure you would breathe in with. Now, a pressure of 14 is kind of a moderate pressure. The EPAP, or exhaled positive airway pressure, at 10 is the pressure you breathe against. Now, the exhaled pressure keeps your throat open. The inhaled pressure opens everything up. It opens your throat, your lungs. And then when you add a spontaneously timed rate, the system will guarantee give you a breath based on that rate. Now, I gave an example of a rate of 10. Now, there's 60 seconds in a minute. You divide it by 10. Every 6 seconds, the system will give a breath at that pressure of 14, regardless of what the patient's doing. It just gives you the breath. Now, what I've found is this type of treatment does take a little bit more time to get synced with, depending on how aggressive that rate is. A normal respiratory rate can be between 8 in 14, 8, and 16, depending on the person. So you don't want to set a machine to where it's going to out-breathe a patient. If you had a person on a rate of 20, it's like they're exercising, and the system is just constantly puffing at them, breathing at them, breathing at them. Every 3 seconds, they're getting a punch. Unfortunately, in my career, I've seen patients come in with a situation like that and saying, I can't do this, I can't use this, I can't. And you look at the reports, you look at the data and say, well, that's why. The system is trying to overbreathe you. You don't want to do that to somebody. You want to tone it down and give them what would be a normal rate that somebody would have for normal breathing that is comfortable. This also is one of the most advanced treatments. It's generally used in the treatment of central sleep apnea or complex sleep apnea. So central sleep apnea is more or less the brain not sending the signal to breathe. And that sounds scary because it is a more advanced form of apnea. It's something that needs to be handled, taken care of. It's a really life-threatening condition. Complex sleep apnea is, that's a fun one. It's basically a person goes to sleep, they snore, they stop breathing, they gasp for air, and they come in, they get a sleep study. We find, oh, yes, you have sleep apnea. Let's put a CPAP on you. We put a CPAP on, and then all of a sudden the body doesn't want to follow suit. So that's when the more advanced forms start to come in, and the BiPAP at the backup rate starts to come up. This can be done in a sleep study. It is used for, like I said, for central sleep apnea. Right now, we're using it for patients that have typically a lower heart function with central sleep apnea or complex sleep apnea due to some guidelines regarding the next form of treatment. But it does work, and it does work quite well as long as we have adequate or accurate pressures, and the respiratory rate is a comfortable rate. Now we have the ASV. It stands for Auto Servo Ventilation. This guy's been on the market, I'd say, maybe 15 years it's been to come out, 10, 15 years. It is... Sorry about that. So as I said, it's been on the market for maybe 10 or 15 years, and it is the gold standard, in my opinion, for the treatment of central sleep apnea or complex sleep apnea. It can be aggressive, though, depending on the complexity of the apnea and how much the system has to pressurize. So again, the pressure ranges from as low as 4 to high as 25. Typically with this treatment, there's going to be a BiPAP-like function, meaning there's going to be a pressure you inhale with and a pressure that you exhale with. Now, the exhaled pressure, a lot of times is very stable, and it typically can be pretty low, something at a mild 5, 6, 7. A lot of times we see. It really just depends on a person-by-person basis. The exhaled pressure itself is, again, designed to hold the throat open. Pressurizes the throat, keeps it from collapsing, stops the obstructive apnea type component. Now, the inhale pressure on the ASV machine is kind of where it gets slightly aggressive. We typically have just a base inhale pressure, something about 3 points above what you breathe against. While a person's awake and consciously breathing, the air pressure can a lot of times feel pretty smooth and pretty comfortable. The system is, you're breathing with the system. It's not breathing for you at this time. Person falls asleep and they may start exhibiting some of the more central or complex apneas. And that inhale pressure has some augmentation where it can adjust pressures up higher and higher to more or less trigger a person to breathe. It a lot of times a patient, when they first start on this treatment, can complain. They wake up with a lot of air. I feel like the air pressure is super high, super high. And we can run a report out of the system and see, well, yeah, your system was peaking out. It was hitting 20, 25. And, it was doing it for a reason. And you woke up, which is a good thing. But it's bad that you woke up. But this is how we would work on getting you back to sleep. The process of reinitiating sleep as we don't want to wake up from the machine or from the pressures. But when it comes to the world of complex and central sleep apnea and the way this particular machine works, like I said, it can sometimes aggressively pressurize air. Better to wake up. This type of treatment does require a lot of strict qualifications through insurance. There's generally multiple sleep studies for this machine and the BiPAP ST and the VPAP ST. There can sometimes be up to 3 sleep studies to get this particular treatment. Also, this treatment itself would be, if used for somebody in respiratory failure, one of the ones that would work. The BiPAP itself is great, but you want to be able to give and guarantee breaths, where the ASV can do that, the BiPAP at the backup rate can do that. But as I said, this system does require pretty stringent insurance qualifications. A patient has to prove in an in-lab setting that they have central sleep apnea and a lot of apneas. They can't just have a couple sporadic here and there. A lot of patients have central apnea. I have central apnea. I've done a sleep study and I have felt apneas myself, the central apneas. I've felt them. But you have to have a substantial amount to even get on this planet. More than half the breathing issues that you have to be central related to even touch this as a treatment. So, disadvantage. Most common disadvantage is nobody wants to use a CPAP machine. Nobody wants a mask on their face. I can't blame them. I put a mask on my face. I've slept with a mask. It's not fun. It takes time. It absolutely takes time. Some people, their response rate's like a bottle rocket. Instant. The first night they slept with it, oh my gosh, it's the best sleep I've ever had in my life. I feel like 1,000 times better. And then there's always some sort of tail effect. You'll get a patient that says, you know what, that first night I slept good, but you know what, I don't think I'm not sure if I'm as good as I used to be. And some of that's normal. Like, your body caught up on some sleep that it hadn't been able to do. And you're probably where a normal person would be that, periodically gets tired throughout the day and maybe had a crappy night's sleep. That stuff happens. But the adherence to using a CPAP is always the stigma. It's always the hardest variable is, I don't want to do it, I'm not going to do it, or I don't know why I need to do it. And that's kind of one of the steps where we like to clear the mud of, why are you doing the CPAP? What is the point of it? Because there can be patients who are not physically tired, but they might have a heart problem, or they might be dealing with some thyroid issues or some associated factor that's linked to, sleep apnea that they're dealing with as well, that using a CPAP fixes, or more or less ties in, makes easier, balances things out. It can also be costly. With the world of insurance these days, most plans have high deductibles, meaning we have to pay X dollars before our insurance even does anything. And that's a variable that a lot of people don't understand unless you are in the insurance world. We know we have insurance. We hope insurance covers things, but some people just have the catastrophe style plan where they have to spend $4,000 or $5,000 for the insurance to do something. So the cost of the machine is a disadvantage. We do have programs where, systems are sold for, as a used machine. Patients have, they weren't able to tolerate, they gave the machine back. The system is basically refurbished and we sell it at a cheaper rate just to make sure we have patients on treatment. There's a couple programs we have to help people with their financial deductibles and such, where package deals where you pay X dollars and you get a multitude of different services that we offer. The masks. That's another winner. Masks are the one thing that if a person could use a CPAP and not use a mask, this would be 100% compliance across the board.
Yeah.
But because you have to use a mask, and there is no way really generally around it, there's headgear. There's silicone seal in your face. Some of them have foam, but generally it's a rubber seal that's placed on your face. There's marks. There's sometimes you can get these nice, cute strap lines right down the sides of your face that last hours. Is there ways to get around it? Sure. There's different types of masks. You got, like a style like this guy. It's a cute little guy. Real popular style these days. Not a whole lot of actual surface area on your face. You have, like a full face mask like this, where it just goes under, not like a big bar. There used to be giant straps across the forehead. They would be like, almost like putting on a space helmet, try to go to sleep at night. And, it worked. Was it fun? No. Did it do its job? Yeah. You get poor maintenance from the system. You get people who just don't take care of their stuff, or they don't replace their supplies when they're worn out. The equipment itself there's a life, just like shoes. Like I like to use the shoe analogy. It's like eventually the soles of your shoes wear out. The insoles wear out. You don't know they're worn out until you put a new one in. And then all of a sudden you can feel the difference between the new one and the old one. That's how some of these masks are. Like you put a new seal on it and wow, oh my gosh, it's so much more comfortable. I don't have to over tighten it. It doesn't hurt my face anymore. Of course, pressure issues. If a patient has to use a really high air pressure, I just had that a little bit ago earlier. A guy he just was getting punched with air, and we had to find a fine balance between what may work for him and what will be effective and what he's going to be comfortable with. And we have an idea where to go. So that's where working with somebody like myself or the doctors, or we can find a balance for you. We can find some sort of way to make this work if you want to accept the treatment. The cognitive behavioral therapy element, like I said, like I put on here, success by 148%. People who understand and know why, what, and how, the reasoning for using this, not just because you snore, is why a person can benefit from it, what it's doing, how it's working. So I'll tie into any questions, anything that a person might have. Let me find my chat.
And most of you are muted, but feel free to, there's not a lot of people on the call, so if you prefer to talk and ask a question,
yeah,
feel free to unmute yourself. There's a little red microphone, or if you want to, actually I could probably just unmute everybody here. I think I can do it. If anybody has any questions.
Hi, can you hear me?
Yes, hi.
Hello.
Hi, I do have a question. I came in a little late, so I don't know if you had talked about something like this or not. But when my pressures were first set, they were set too high.
Yeah.
So that, let me go back a little bit. My mouth drops open when I sleep.
Okay.
And also my pressures were set too high. So what was happening is my mouth was dropping open and staying open, and my whole throat and mouth were drying out by the time I would wake up.
Mm-hmm.
I could barely swallow.
Right,
so they dropped my pressures down a little bit. Can you still hear me?
Yeah.
Yeah, so I dropped my pressures down a little bit. And of course, I still have the problem with my mouth dropping open. Okay. And it also seems when my mouth is closed, air tries to sneak out. So I'm thinking my pressure is still, that's just what I think. But to stop my mouth from opening, I was using a jaw strap, which wasn't even working. Sure. So I started mouth taping.
Okay, yeah.
And I found that the combination of jaw strap, yeah, the combination of jaw strap and the mouth taping work. But I still feel like sometimes there's air trying to sneak out of my mouth. So is my pressure set too high?
Now, there's a possibility. Now, does this happening when you're trying to go to sleep, like you're awake, you put the mask on, you feel it, or is this something that's waking you up?
It's something that's actually waking me up.
Okay. So, one thing we don't really know in the night is how we woke up, what level of sleep we may be in. But it's common for a person to maybe be in our deep REM sleep and have a little bit of jaw drop and some relaxation due to the effect of what REM does to our body.
Mm-hmm.
That's where patients might notice some blowout, which is what you're getting, some blow through. Now, are you using a regular CPAP machine or an auto PAP?
I'm on a BiPAP auto.
And a BiPAP auto. Okay, so now it's adjusting two pressures up and down. So one thing that may work and may help is finding like on a report, a download report, finding a level that you're kind of averaging. Some level, there's always a low end, a middle, a moderate level, and a maximum level that your system spends time at. And it's like sampling, stabilizing the pressures can help. Like programming to stop from going up too high, and you might not get blowout. The other variable is trying a nose and mouth mask, a full style. You're not using that stuff, so that can be helpful.
Yeah, I tried the full face mask, and my mouth drops open so far that I will wake up with the bottom of the mask in my mouth.
You got some bad jaw drop. So there's a couple masks that work really well with that, with jaw drop. It is a nasty beast to deal with, and that generally you kind of maybe err to a little bit size larger to kind of play with some spacing. Sometimes a patient will use a chin strap with the full face mask to keep your mouth from flying through the bottom of it. Those do help. But I think getting a report from your machine, finding some stabilization in your pressures, because it could be over-pressurizing at this time. What's nice about the reporting of a machine like a BiPAP is it gives some very detailed reporting of what's happening kind of minute by minute. Like I can see when the pressure went up and what the mask response was or what the leak response was to it. And I can get, based on timing, you can get a general idea of, well, okay, it's been X amount of minutes since you've been sleeping. You might be in deep sleep at this point. You might be in REM sleep here. And then we can try to play with pressures and hopefully keep your mouth from blasting open, keeping you from having to tape your mouth shut.
Okay, you actually get my reports, so should I just call the sleep center? Okay.
I have some slides ahead that are, how to schedule an appointment and such like that. But if you're already an existing patient, you can always schedule. And what location do you typically go to?
Scottsdale.
That's where I'm sitting right now.
Oh, good.
Yeah,
okay,
if any of you on the call would like to make an appointment with Andrew and you're already an existing patient, he'll show you how to go online and actually schedule a CPAP follow-up with him. If you're not our patient and you would like to learn more, we're doing virtual visits. So no matter where you are in the country, you can meet with one of our sleep specialists. We can kind of go over what you might need. If you need a new study from where you're at, we can actually even mail a disposable home sleep test right now. And you can do a follow-up with Andrew later on online. We're doing virtual visits. So, and we're going to be doing this call every Friday. We have one Friday where it's noon, but valleysleepcenter.com. Click on about, and then events is all of our events. And, it's just a great resource right now. We have extra time, and we're really, really thankful, Andrew, that you've given us such great information.
So, anybody else have any questions?
Can you hear me?
Yes, I can hear you.
I've been using just the one that just goes underneath the nose, but it seems like either my allergies or a cold or something, and it's made my nose very sore. So I had to stop using it.
Okay.
And I've had the medium size I used for quite a while, and it says it was working, but I have insomnia too, so I don't sleep that well anyway.
Okay.
But it got to a point where it says I'm not making a good mask seal. So I went to the small size, and it felt like I was getting a good reading, but the next morning it still says I'm not making a good mask seal. But I stopped using it for about a week now because my nose has been running, and I dropped the humidity down to a number 2, but it just doesn't seem to be able to work.
So of course now it's allergy season, which can't be any better timing to have allergies and a cough while we're supposed to be hiding from everybody that's coughing. So sometimes the humidity going up can actually help the nose issue. Using some vitamin E oil, coconut oil can help keep your nose from getting raw or red. It helps for pressure sores and such. The machines can be pretty sensitive to that mask fit. A person can leak for kind of a small period of time, and then before you know it, the system, you wake up and it says you had a bad fit. One of the things I ask patients is, does it bother you? Is it waking you up? Do you feel the mask leaking? And if it's a resounding no, and then are you feeling better? Do you feel like the treatment's working? Yeah. Well, then we're 90% here. The last 10% might be wrapping things up, maybe tweaking the sizing, the fittings. Again, the reporting from the machine does give me a pretty much a good blueprint of what's happening to your leakage. If it's mask shift, like you need to try a different size or a different mask, or is your mouth opening? What is happening? These reports are pretty clear cut when I look at them on what's kind of happening. So sometimes take that mask fit with a grain of salt, but definitely turn the humidifier, try to turn the humidifier up and seeing how that does with the nose issues.
Yeah, I put it up to a number 4, and but then in the morning, the container is like almost completely empty.
Yeah.
But, I still get that mask seal sign that says it didn't seal right.
Yeah. If you're blowing through water like that, it's either happening because of a poor mask fit, which could be the mask is shifted off, it's sized incorrectly, it's a bad fit for you, or your mouth. It could be taking everything out of it. So when the system provides a good fit and the humidity is being retained, those tanks can last 8 to 10 hours. So definitely I would recommend coming in and finding a different mask.
Yeah. Okay.
That's my thoughts.
Tell me to use that snore thing.
Use what?
Snore thing. Keep your mouth.
Yeah, I use a chin strap too to hold my mouth closed.
Okay.
But, plus, with the insomnia, it's hard to tell if I'm waking up because of the machine or just waking up. I'm taking sleeping pills along with it, and I never sleep through the night. I'd give maybe an hour and a half, 2 hours tops. But one thing
consolidated sleep.
Yeah. One thing I do like about it, I don't know why it works, but it seems like I don't have to get up and go to the bathroom during the night. It doesn't bother me.
And that probably means that the machine is controlling the apnea well, and it's just slowing down your need to use the bathroom.
Right.
Even while you're using it, it's at least a little bit more consolidated sleep. But obviously, if you're having some significant mass leak, that can cause a lot of arousals and cause a person to just be disturbed and disrupted in their sleep at night.
Right. Right.
So,
We'd be happy to help you with that insomnia as well. So
Yeah, absolutely.
Go ahead and show them how to make an appointment. Cool.
So I have a couple slides. Of course, the first slide on the left is the General Valley Sleep Center homepage, and under locations, there's the right now I'm typically linked out of the Glendale Sleep Clinic. I know that Lori's changing that around a little bit, trying to get me some other offices, but I am generally in person out of Arrowhead, Scottsdale, and Biltmore. I'm, of course, doing virtual stuff, so you can see me on the tablet, and I can see your pressures and kind of fine-tune and tweak things individually. But Glendale Sleep Clinic, next page where click to make an appointment. Then we have this, schedule an appointment online. And then you have the existing patients or a new patient. If you're a new patient, you would have to schedule a consultation first. Come in and get established as a patient before you could come and see me. Existing patients can follow up with me. Arrowhead Center, and I am under the CPAP follow-up because that's where I spend my life, following up with CPAP machines. And that went the wrong direction.
You have an appointment April 13th for Sleep Center.
All right. Anybody else have anything? Was everybody able to hear me well?
You sounded
Yes.
great. Yeah.
Okay. See me, hear me. I wasn't sure. I hadn't. I never used this tablet as a video before, and this first time for everything.
It was great. Thank you so much, everyone, for joining. And Andrew, thank you for your expertise. We really appreciate you.
Excellent.
Thank you.
Invite your
Thank you.
friend next Friday, 4 o'clock. We're going to do it again. Thank you, everyone.
Okay.
Thank you.
Thank you.